Good afternoon, everyone. My name is Mark Skidmore. I'm the director of the North Central Regional Center for Rural Development, and this is a series today's presentation is a part of a series titled Combating Opioids webinar series, and it is funded by a grant from the Rural Health and Safety Education, USDA. And we are doing this in connection with and collaboration with Purdue University Extension. So again, thank you for being here. While I introduce the topic, you will see on your screen a couple of questions. We're hoping that you can fill that out. It just takes a moment. So thank you for that. That helps us understand who our audience is. Today's topic or title is called Recognition and Stigma in Prescription Drug Abuse and Alcohol Abuse, and our two speakers are Robert Shupp and Scott Loveridge. They're both professors here in Agriculture, Food, and Resource Economics at Michigan State University, and they're going to talk about a nationally representative survey in which actually I was a part of this project as well. And we conducted a nationally representative survey evaluating literacy with regard to prescription drug abuse and alcohol abuse. And one of the contributing factors in the opioid crisis is lack of understanding about potential drug abuse and being able to recognize it. And so with that, I'd like to introduce Rob and Scott and have them take over. I will also note that there's a little chat section down below. Some of you have already used it. If you have a question that you'd like to pose along the way, please type it in there, and then the speakers can address it either along the way or at the end. So again, thank you, and thanks Scott and Rob for giving this presentation.
Well, thank you, Mark. This is Scott Loveridge talking now, and just wanted to first start by acknowledging some of our project partners in the project that Mark mentioned briefly. The project was called CAPE, which stands for Community Assessment and Education to Promote Behavioral Health Planning and Evaluation. And the primary source of funding was the Substance Abuse and Mental Health Services Administration. And those funds were coordinated and managed by the U.S. Department of Agriculture, National Institute of Food and Agriculture. And it was really a partnership of the 4 regional rural development centers that managed this national project with participants from really a lot of different institutions involved in thinking about it. This slice we're going to talk about today is based on some preliminary analysis that came out of part of the project. Mark mentioned Rob Shupp and myself and himself. Other partners on it were Don Albrecht from Utah State University and Brandon Green, who is now with the Development Services Group. And with that, I think I'll turn it over to Rob.
All right. Thank you, Scott. This is Rob Shupp. Again, thank you all for coming. I will be talking through most of the presentation. So first, I'm just going to talk about the regional nature and the economic issues involved with prescription drug abuse and alcohol abuse issues. And then we'll talk about the survey itself, go through some of the survey results, and then Scott's going to take over and talk about some possible community responses as well. All right, so to begin with, let's see if I can control the little... All right, so to begin with, I just thought I'd point out that both prescription drug abuse and alcohol abuse have a regional aspect to them. They vary by county, as you can see in the map here. This is for overdose deaths involving opioids. That's pulled from theeconomist.com, but it's from the sources, Center of Disease Control and Prevention, and as most of you are probably aware, you can tell by the map that opioid deaths, overdose deaths, are definitely regional in nature and vary from county to county. And then also for alcohol abuse, that also appears to have a regional nature and vary by county. As you can see, given this map here, this is the prevalence of binge drinking in 2012. The source of this is the Institute for Health Metrics at the University of Washington. As you can see, Utah has relatively low prevalence of binge drinking, whereas the upper Midwest and Michigan and that area has a higher prevalence of it. So I guess the point of that is just to illustrate that there is this regional county by county difference that may play a role when we talk about the sources of recognition and stigma. So in terms of the economic costs, both prescription drug abuse and alcohol abuse create both direct and indirect costs. Direct costs would be healthcare. Some examples of indirect costs would be days off work or lower productivity. In fact, these costs can add up to quite a bit. For prescription drug abuse, cost to U.S. society was estimated to be about $500 billion in 2015. Many of you, I'm sure, have seen this report. It's the counts from the Council of Economic Advisors, released in late 2000 or October, I think, 2017. And then also for alcohol abuse, cost to U.S. society a little bit further back in 2010 was estimated to be about $250 billion. And that was in a paper by Sachs et al. So overall, both of these issues create some definite problems that we would like to try and address. In the particular research that we are presenting today, we're taking a look at recognition and stigma for these two substance use disorders. And both of these substance use disorders are definitely treatable. And however, if you do not recognize that you have a disorder, then it seems right that you are much less likely to seek treatment, or that the treatment itself might be delayed. And then clearly, stigma is going to play a role in treatment seeking as well. But we'll come back and we're going to address recognition first, and then I'll come back and talk specifically about the stigma issue. But before we can do either of those, I'm going to talk a little bit about the survey itself. So it's actually two different national online surveys. Both of them had about 630 respondents. As you can see there, these were separate surveys done individually with different people but they were both done simultaneously. So in terms of when they were given around the same time. The samples were balanced on age, gender, income, and region. And we included a rural oversample to make sure that we didn't just hit the metro areas. We insisted on a rural oversample based on USDA urban continuum codes. And I think the breakdown was around $500 or 500 respondents in each were just nationally representative, and then there were about 130 that were oversampled from rural areas. Excuse me. The primary activity within each of these surveys was a response to a vignette, and we'll see those vignettes on the next two slides. The vignettes were split, so half the respondents saw a vignette based on that involved a male, and half of them saw a vignette that was based on a female. As part of the response to the vignette, participants were asked to actually identify what was wrong with, or what they thought was wrong with the person in the vignette. And then they were also asked a series of questions designed to identify whether there was stigma, whether that individual had potential stigma towards those types of issues. All right, so the first vignette is right here, and I think we're going to do a poll, but I'll go ahead and read through the vignette. Is there a way to adjust the poll? Oh, there we go. So the vignette that we used in one of the surveys was Michael is 30 years old. He went to see his doctor after experiencing a work-related injury, and the doctor prescribed a painkiller, hydrocodone, brand names of Vicodin, Norco, Lortab, for Michael to take. He started taking the painkiller as instructed by the doctor, but felt like it was not enough to control his pain and started taking an extra pill every day. After a follow-up visit, the doctor told Michael that his injury had healed and that he should stop taking the painkiller, but he continued taking it until he ran out. At that point, he felt like he needed more of the painkiller and went to a new doctor to get a new prescription. So if you could take a moment and answer that poll, the question that the respondents saw, this is pretty much exactly what the respondents were answering. The question is, what, if anything, would you say is wrong with Michael? And it's a select all question, so you can select multiple answers. So I'll give you all a chance to respond. So it looks like everybody has more or less answered. So I don't know how we go ahead and stop the poll or broadcast the results. All right. Thank you, Rosa. So as you can see, and as I would suspect, most of you, 97.5, it looks like, % of those that responded indicated that there was this individual had a prescription drug abuse problem. And then 35% of you also put down has a problem. A couple of you indicated depression, psychological, emotional problems, or stress, as well as physical injury. And as it turns out, those results are, as you can imagine, better than we got with the average person. So I'm going to move on to the next slide. Can I do that? Yeah. So the other vignette that we used, so that was obviously the vignette for the prescription drug abuse survey. The other vignette was for the alcohol abuse. And in this one, Michael, again, is 30 years old. He drinks at least 3 alcoholic beverages every evening after coming home from work. He is very active in his office's monthly social events and regularly drinks at least 5 alcoholic beverages at each event. He has started having trouble completing tasks at work, feeling overwhelmed, and as though others don't appreciate his efforts. His boss has noticed his lower productivity and that Michael does not seem to be interacting well with coworkers. One note, for the alcohol abuse vignette, when there was the female involved, the vignette number of drinks was changed to 2 and 4 in order to better reflect definitions for alcohol abuse. All right, so moving on to how the individuals responded to this. So the recognition part of this was what is wrong with either Michelle or Michael. And so this is just a list of proportion of responses for both of the surveys. As you can tell, in red, the correct response for the alcohol vignette was selected by 64% of individuals. And for the prescription drug abuse survey, it was a little bit lower at 61%. So the majority of respondents correctly identified what was wrong with either Michael or Michelle, but it was certainly not as high as you all, at least for the prescription drug. So somewhere between 35 and 40% of the respondents did not select the correct response. And so there's clearly some room for improvement here. If we take a look at some of the other answers that were given, for alcohol, depression was one of the ones that was highly selected, and stress, and obviously has a problem was a top choice as well. For prescription drug abuse, has a problem, definitely was selected, as well as depression, psychological, emotional problems, and stress, as well as physical injury, but that wasn't chosen quite as high. So overall, people could recognize what was wrong with X, but there was definitely a not insignificant portion of the population that was unable to correctly answer that. So what we did is we took those results and we were trying to identify, we're going to try to explore the determinants of recognition and who was able to respond correctly relative to not, in hopes of being able to better identify and target education to those that are not able to identify these types of issues. So what we did is we did a logit regression on whether or not the respondent clicked the appropriate condition. And then we added into that regression control variables. And they included respondent socioeconomic characteristics like age, gender, income, education. And then we also included regional variables from the census and a selection of variables indicating the conditions in their country of or county of residence. Excuse me. So the primary results.
There's a question in the chat about whether the male person in the vignette or the female, whether it made a difference. We tested for that, and basically the answer was no.
Well, it did make a difference in the alcohol, vignette in terms of recognition, but it did not make a difference in the prescription drug abuse vignette. We think that it made a difference in the alcohol abuse because of the lower level of lower number of drinks involved. So Scott, thank you for pointing that out. So what were the results of this regression for? We'll start with the prescription drug abuse. Males were less likely to recognize to indicate that it was prescription drug abuse. In terms of age, the younger you were, 18 to 34, the less likely you were able to recognize it. And the older you were, 55 plus, the more likely you were to recognize prescription drug abuse. And all of that's relative to middle-aged folks between that 35 and 55. Turns out that income really didn't play a role. That people with higher levels of education, so either some college or a college degree, are more likely to recognize prescription drug abuse than people with a high school or less education. Respondents from counties with high mental health provider access are interestingly less likely to recognize prescription drug abuse than those from counties with the lowest access. We found that to be an interesting result. And then finally, respondents that self-identified as having had a prescription drug abuse issue are less likely to be able to recognize that issue. Specifically, the self-identification comes from a question where they asked at the very end of the survey, or before the very towards the end of it, have you ever had what you would think of as a prescription drug abuse issue? So that's kind of how we indicated whether they self-identified or not. In terms of the determinants for alcohol abuse, in terms of age, it's very similar to the prescription drug abuse. 18 to 34-year-olds are less likely, 55 plus are more likely to recognize alcohol abuse. Income here made a difference. People in the $75,000 to $100,000 income range, so slightly above average, are less likely to recognize alcohol abuse than people in the $50,000 to $75,000 income range. People with, excuse me, people with higher levels of education, so above a college degree, are less likely to recognize alcohol abuse than people with a high school or less education. Respondents from counties with higher per capita number of social organizations, so these include religious, recreational, like bowling leagues, or professional organizations, are less likely to recognize alcohol abuse. And then finally, respondents that self-identify as having had an alcohol abuse issue are also, again, less likely to recognize alcohol abuse. So that's very similar to what we had with prescription drug abuse. All right. So Scott, if there are questions that I'm not seeing in the chat room as I'm moving through this, if you want to bring those up, that would be great. All right, so moving along to the stigma analysis. All right, so just a little more background on stigma and kind of why it's important. I think probably most of us think it's understand that it's relatively important, but Livingston et al. Have noted that substance use disorders are more highly stigmatized than other health conditions, and stigma may cause incomplete or delayed treatment. And then delaying or not getting treatment can impact a whole host of things, areas of life, including employment, social relationships, and can lead to poor mental and physical health. And then, I don't know if Scott had wanted to jump in with this rural concern issue down here. It's a
Yeah, thanks, Rob. So actually, this came from Allison Brennan, who I see is on the session today. And since it is a rural safety and health education group that's sponsoring this, it's important to think about how these things might play out differently in rural areas. And nice little example of how that might happen in a rural area is nobody wants to go into the church on Tuesdays because they know that there's a self-help group meeting happening there on Tuesday, and they don't want to be associated with that activity. So it's little simple things like that can really stymie efforts to get people some help that they need if they're so afraid of going into the church because people might think they have that problem. They're much less likely to seek treatment. So it's could be that the issue plays out differently and the solutions are different in rural areas. So I'll turn it back over to you, Rob.
All right, thank you, Scott. All right, so looking at the stigma analysis. So what we did is for both prescription drug abuse and for alcohol abuse, we focus our stigma analysis on a level of agreement with the following statement, and that is X's problem, so it's either Michelle or Michael's problem, is not a real medical illness. And right here are just the frequencies and percentages of answers to that question, or levels of agreement to that question. And as you can see, about 22% of people either strongly agreed or agreed with that statement when it was presented in the context of prescription drug abuse. All right, so those are, I would imagine, relatively high levels of stigma. And then for alcohol abuse, I was a little surprised myself that it wasn't lower, given how much people know about alcohol abuse and how much it's been discussed. But about 18% either strongly agreed or agreed with that statement. So there's definitely stigma out there. And so one thing that we might want to think about is how can we not only address recognition, but also address stigma. And so we explore the determinants of stigma as well, using a slightly different approach. We used a multinomial regression. And in these multinomial regressions, what you do is you compare other responses to a base category. And so in this case, we used neither agree nor disagree as the base. And then the output then tells you whether the control variable is associated with more or fewer people not choosing that base. So to, to simplify the comparison even further, we combined agree and strongly agree into one response, and also combined strongly disagree and disagree into a single response. Then we compare both of those to the base, which is neither agree nor disagree. So as before, we're going to use socio-demographic information as well as regional and county of residence controls when we run those regressions. So what did we find? The primary results for prescription drug abuse, we found that the respondent's choice of the correct condition was very strongly associated with less stigma. So you were 5 times more likely to disagree with the statement if you had correctly chosen, had indicated that the issue was prescription drug abuse. All right, and so there is this, it appears that there's a strong link between being able to recognize and stigma. So the second thing that we found is that respondents that self-identify as having had that prescription, an issue with prescription drug abuse, are much more likely to exhibit stigma, and they are, again, 5 times more likely to agree with that statement, that it's not a real medical illness. Then respondents from counties with high mental health provider access are much more likely to exhibit stigma and to agree with the statement than those from counties with the lowest access. In fact, it was 6 times to 9 times more likely to agree with that statement. And then younger folks, 18 to 34, and male respondents were both less likely to disagree with the statement, so to show slightly higher levels of stigma. And then people with higher levels of education, the highest levels, college plus, so greater than a college degree, are more likely to agree and show stigma than those with some college, and those with some college are more likely to disagree with the statement than people with a high school or less education. What about the results for stigma and alcohol abuse? The respondents, again, the respondent's choice of the correct condition was strongly associated with less stigma, a little bit less strongly than in prescription drug abuse. You were 2.7 times more likely to disagree with the statement if you correctly identified the issue. In terms of age, the younger the respondent, the more likely you were to agree, or to show higher levels of stigma, while older, 55 plus, were more likely to disagree or show less stigma than middle-aged folks. In terms of income, lower income, so less than $25,000 respondents, were less likely to disagree. All right, so they show slightly higher levels of stigma, while higher income folks, 75 to 100,000 respondents, were more likely to agree with the statement and also show higher levels of stigma. People with higher levels of education, so some college or college, are more likely to disagree with the statement than people with high school or less education. So they're more like, they show a little bit less stigma than those with a high school education or less. And then finally, respondents from counties with higher mental health provider access are less likely to disagree with the statement than those from counties with the lowest access. So if they're less likely to disagree, they're showing slightly higher levels of stigma than those from counties with the lowest level of access. So, overall, conclusions from the analysis. While the majority can recognize behavior and symptoms associated with prescription drug abuse and alcohol abuse, there's definitely room for improvement, so that 35 to 40%. Education could possibly bring those percentages higher. Young adults seem especially in need of prescription drug abuse education, both in the context of recognition and stigma. Young adults of both genders need alcohol abuse education. And then I would also throw in that there appears to be this strong link between recognition and stigma. So one way to address stigma indirectly is clearly, or at least it appears that it would work. You could do that through addressing recognition as well. And then finally, access to mental health services does not seem to reduce stigma for either prescription drug abuse or alcohol abuse. And there may end up being scope to increase the activities of mental health service practitioners in terms of educational activities. So you may be able to target specifically stigma education through these mental health service providers. All right, and then I was going to turn it over to Scott, and he was going to talk about potential community responses.
Well, thanks, Rob. And there's some really good chat going on here too, so keep that going as well, because we don't have all the answers, but there are a few things that we're trying. Through the CAPE project, we put together some materials to help extension staff improve mental health literacy and to organize this at the community level. So we had there's some material that is called mental health first aid training, and it's very analogous to CPR kind of idea of being able to recognize what's going on and step in and help the person. So there's training on how to see what it might be, and then how to engage the person about their issue. And Courtney has very helpfully put in the link there, so thank you, Courtney, for that. And so we started with that, and then we built around that some tools that can be used at the community level to get the community engaged in this process of delivering mental health first aid training. So community action planning, community needs assessment, kind of where do we get data about what's going on in our community related to these issues. Looking at community preparedness, engaging the community in the solutions and building consensus around it, and then creating a strategic plan and then implementing the plan. So that's a set of materials that's already been put together and tested in a couple places. So I encourage you to tie into that if you want. And Mark Skidmore has helpfully put the CAPE resources link in the chat, so you've got that as well. And then at MSU Extension, I don't know if Rosa, if you're listening to this, I'm wondering if you could enable Courtney to speak, because she's leading this effort. MSU Extension has formed a community behavioral health team, and really looking at improving behavioral health literacy and community responses to mental health and substance use issues. They're doing mental health first aid trainings around the state. I don't know, I've lost track of how many you've done, Courtney. You've got speaking ability now if you want to say anything. But I think it's quite a few around the state, and then also some produced materials as well. So, well, there you go. Courtney can't speak, but she's willing to take email questions. So you've got her contact information there at the bottom. So the bottom line is that there are certainly things that can be done in this context to try to overcome some of these recognition and stigma issues. to me, it seems like the low-hanging fruit is really working on the recognition, because the two surveys, our analysis shows that recognition is really key to reducing stigma. So instead of trying to attack the stigma head on, you just educate people about, this is a medical condition, here's how to recognize it, here's what to do. And I think if you frame it in that way, it's much more easy to overcome the stigma issue. And I'll turn it back over to Rob. And Rob is not there. Okay, now you're back.
Thanks. Yeah, sorry. So these are just some references that we had, and I really do not have a whole lot more to add other than there's our contact information. If you do have any questions, you can please feel free to email either Scott or I, and we would be happy to get back to you on that.
And so Courtney has entered Courtney's entered the URL for the Community Behavioral Health Group at MSU Extension, so take a look at that.
Well, thanks, Scott and Rob. This is great information. I would also add in the link that I provided, the Health Bench info link, there are some infographics, and one of the infographics is for prescription drug abuse. And so that might be a resource for you as well. You can just download the PDF and print off or forward on if you like.
Well, there's an alcohol abuse one too.
Yeah, alcohol abuse as well. Did you see any questions that you wanted to address in that chat session? There were a lot of really great comments and thoughts.
Yeah, I think my answer to most of them, and Rob, you can chime in if you'd like, is really, so there's a question about small towns, how to deal with it in a small town. There's questions about, people think it's completely normal to drive around with heavy equipment with a beer in your hand. I think just working on the recognition issue, and don't tell them that they've, use the tools that are in the trainings to do that, but start with the recognition issue, and then work up to the other. Yep.
Good. Well, I think you all can see our little questionnaire. Really appreciate your feedback on this webinar. Are there any last comments or thoughts from either of you, Rob or Scott?
Not at this time from me.
Well, thanks for hosting, and I think we want to make sure that we talk about the upcoming webinar.
Yes.
On March 29th.
I'll pull this in. I'm afraid I'm going to cover up the evaluation here. You see that okay? So our next seminar will be on March 29th at 2 p.m. Eastern Standard Time. Shannon Manat from Syracuse University will be talking about More Than Opioids, the Social Determinants of Drug Overdose and Related Despair in Rural and Small City America. So that'll be our next webinar. I'll leave the site open just so that some can finish the questionnaire. Otherwise, thanks again to everyone for joining us, and thanks Scott and Rob for some really useful information. And everybody have a good afternoon. Thanks.
The suggestions coming in on the chat are great too, so I encourage everybody to read those.